Hey there. Thank you so much for joining us today. I'm Maryal Concepcion. I love DPC. I'm a DPC owner in Northern California, and I'm so excited to be joined here today with Jay Keese from Capital Advocates, but also, most importantly, the DPC Coalition. So, we are going to be having an amazing conversation today that a lot of people are tuning in for because everybody's asking, where is DPC when it comes to Capitol Hill? And Jay is here to deliver those answers. So, Jay, thank you so much for joining me today on this conversation. Tell us a little bit about your background and how we got here today.
Well, thanks, Maryal. It's great to be here, and I know everybody wakes up every single morning and hears something new and different coming out of Washington these days. Certainly since the inauguration of our current president, it's been a challenging environment to just keep awareness around. So we want to level set today and talk a little bit about what these changes mean, particularly for DPC. My background, I think a lot of people know that are probably tuned in. I run the Direct Primary Care Coalition. But I'm also CEO and principal of Capital Advocates, a DC-based lobbying firm. We do a lot of other things for other clients as well. We recently started working with the National Organization for Rare Disorders, so helping people with rare diseases, run the Partnership to Fight Chronic Disease, which is a widespread coalition of stakeholders interested in treating chronic disease, and of course DPC is a big part of that. Have been involved in lobbying since a long time ago, before most of the people that are logged in for this podcast were born. I worked for the American Medical Association as a lobbyist for about a decade in the early 90s and through the 90s. And I've worked in the arenas of health IT and pharmaceutical IP law and other spaces, but have really mainly focused on representing the interests of physicians and patients in the healthcare system for the last 10 years or so. Got my start with DPC with the very first DPC practice. Garrison Bliss came to Washington as the Affordable Care Act was unraveling to try to have an impact on that so that it wouldn't put the budding DPC industry out of business. And Garrison and I together built the DPC Coalition in response to the legislation that we put in the Affordable Care Act back in 2010, which allows DPC practices to be part of the essential health benefits requirements, both in the exchanges and working with employers. And that led to an awful lot of legislation being passed in over 35 different states to sync with that. And we've really been huge fans of DPC ever since, and right from the very beginning, and are really happy to be working to try to forward the interests of patients and physicians in getting better primary care to all Americans. So really super psyched to be here with you and to follow up on the great presentation we made at the last HINT Summit to sort of give people an update on where things stand today.
Yes, and definitely you'll be given the link. It'll be made available if you are like, oh my goodness, what are they talking about? I am new to this, arena of where DPC is on Capitol Hill. Please watch the video that Jay and I did, a presentation at HINT Summit back in September of 24, where we talked about just the update of DPC as of that point. And now we're going to bring you up to date with what's happened from September to now. And I will drop here, if you're interested, we'll be mentioning how to get involved, and definitely keep in mind in August 24th to 27th, you can hear more about what's happening on Capitol Hill at HINT Summit. It's going to be in Denver, HINT Summit at Rosetta Fest. So make sure you have those dates. It's dropped here below our pictures, August 24th to 27th. So Jay, let's get started with, you mentioned some of these key things that people are really interested in right now. A new administration, you definitely mentioned that. We're past the first 100 days now. The MAHA movement, names like Dr. Oz and RFK floating around. So tell us about where DPC is fitting in, given that it's very bipartisan coming into this administration.
Yeah, certainly. And this is the good news. You mentioned it, that DPC has always been a bipartisan effort. We have had people on the political spectrum as far to the left as Earl Blumenauer, who recently retired as one of our key champions on DPC legislation, and Dr. Bill Cassidy from Louisiana, who now chairs the Help Committee, a Republican doctor, conservative from Louisiana, and everybody in between. But obviously, we're living in very partisan times, and so the good news is we've been able to keep this partisan balance, this bipartisan balance going. And we intend to work on some of the things that the first Trump administration did to try to, move that along. The first Trump administration was very supportive of getting DPC into Medicare and to Medicaid. And we'll talk a little bit about that later. But the efforts they did in the first administration really kind of fell short and wound up becoming what we now know as the ACO REACH program. Started out as direct contracting. I think we'll have an administration that's going to have their ears open and their eyes wide open towards maybe going the next step and doing a program for Medicare and Medicaid that might look a little bit more like DPC. And we've proffered some ideas there. I think a really important factor to remember about this administration is physicians have an outsized voice in this new administration. Dr. Oz is the first CMS administrator to come into that after being a practicing physician for a long time. Tom Price preceded him in the previous administration as secretary, but running Medicare and Medicaid, the largest health insurance organizations in the world, you now have a physician. So I think we're going to be looking at a lot of different things in that regard. Dr. Marty Makary, who's been a big supporter of direct primary care, is now the head of the Food and Drug Administration. So looking at new medications, new therapies, new techniques, whether they be devices, drugs, combination therapy, that are going to be supported by physician-driven evidence base. And Dr. Jay Bhattacharya, who is a physician and a healthcare economist, now running the NIH. Very slimmed down NIH, I might add, but with all of the DOGE cuts that have happened, HHS has been slimmed down. CMS has not had as many cuts. We're looking at exactly what the impact might be there. But again, I think that with the bad news of a lot of these research opportunities, grant opportunities, kind of going out the window at the federal level, the good news is there's a vacuum for physicians to step in, talk about the evidence base that they see real time in their practices every day. And I think we'll have an open ear in this administration, certainly with Dr. Oz, Dr. Makary, and Dr. Bhattacharya. There's also a very much a significantly strengthened doctors caucus in Washington, D.C. It is not only a Republican organization anymore. Democrats have their own doctors caucus. So, we have both sides. And Dr. Roger Marshall, OBGYN from Senator Marshall from Kansas, is leading the Make America Healthy Again caucus over in the Senate side. And we'll take some time to review, kind of like what they're doing over there as well. They're really trying to lead in this administration from a perspective of, what can we do to put patients, providers, caregivers, doctors at the forefront of making some of these decisions. We're excited about that. Now it's time to execute. That's the real big question. Can this administration execute in a way that isn't chaotic, is evidence-based? And that's what we're here in DC to try to, help them shepherd that idea along.
And I love that. And I really echo what you're saying in terms of the physician voice matters when it comes to, you and I have been on Capitol Hill. Clearly, you are a lobbyist. But when it comes to the fact that the DPC coalition with you and Garrison have invited multiple doctors from all over the country to speak about just what they're doing in everyday clinic. We're not necessarily speaking to the policy or the paragraphs in the policy. We are talking about the patients we take care of who have Medi-Cal in California, Medicaid in other parts of the country, who are pregnant, who are, needing access to care, and they still have insurance, but they don't have health care. So I think it's really, really important to just really call that out and agree with that agree with that statement that the physician voice does matter here. When it comes to execution, talk to us more about the MAHA caucus in particular, because with the change in administration, there's also been change in committees. And so I would love if you could tell us more about what should DPC doctors be paying attention to, no matter what side of the political spectrum they swing on.
Well, we've heard a lot about this Make America Healthy Again, movement. It really is. It is a true movement. There's And it's largely driven by moms who are frustrated with a lot of the information they're getting from, science and the evidence base. And so there's a lot of questioning about that. But we were very satisfied and encouraged here that when it comes to Congress implementing some of these ideas, that the Make America Healthy Again caucus was launched by Dr. Roger Marshall. Again, a physician from Kansas. We've had a longstanding relationship, is a big supporter of DPC. We're going to be talking a little bit about some legislation that he's likely to introduce that will work on the MAHA agenda. And I think we have a link to the MAHA caucus agenda right up there for people to see. It's really interesting. I mean, I will note that DPC is really, front and center in this document. Their visions and goals include, treating food as medicine, preventing chronic disease, shifting resources towards preventative care rather than addressing chronic illnesses and sick care on the back end, and using direct primary care, HSAs, telehealth, all of these tools as a way to improve, access to primary care. Also, advancing regenerative and precision agriculture. Now, I will mention that Senator Marshall is a smart politician, and he's from Kansas. So this is going to be very, very important for the folks in Kansas to understand where does food play a role. Every DPC doc that I have ever talked to talks a lot about every single day about what's your diet like? What's your nutrition like? How is food, alcohol intake, other substance abuse intakes, other substance intakes? How is that impacting your health? So really getting down to a lot of the nuts and bolts. Having a guy like Marty McCary at the FDA reviewing the science regarding what are the inputs to food. Today, one of the things that's interesting about the regulatory impact of food is that most food labeling is regulated by the Department of Agriculture, not the Department of Health and Human Services. So will we be looking towards the idea of bringing some of that capacity to bring the regulatory authority around FDA that it has being the gold standard with drugs and devices into our food supply? And physicians have a great voice in this because they're the front line in treating chronic disease. And I think we all know that well over 90% of chronic disease is really linked back to lifestyle and behavior and obesity. So it's an exciting time to be involved in this. And it's really exciting to see physicians in Congress at the forefront of this. Also, on the House side, Dr. John Joyce from Pennsylvania is leading the MAHA caucus there. And the sponsor of our bill on the House side to fix the HSA mess, Representative Lloyd Smucker also from Pennsylvania, is a member of that MAHA caucus, even though he is not a physician, but he's playing a big role. We're also interacting really closely with the Doctors Caucus. And another key name that you remember, Dr. Bill Cassidy, who's the lead sponsor and the original author of our DPC legislation to fix the HSA situation. He now chairs the Senate Health Committee, Health, Education, Labor, and Pensions Committee. So he's moved from a position of ranking member and prior to that, rank and file member, to now we have one of the two lead healthcare committees in Congress being led by Dr. Bill Cassidy, who is a gastroenterologist, but a huge fan of DPC and primary care.
Yeah, I think that, as you say, it's an exciting time to be in this, this where we are in healthcare, where as we're talking about caucuses, as we're talking about bipartisanship. I think also just from the physician perspective, it's so empowering to be able to just really help where people are needing help in their healthcare journeys. Just this morning I was reading about vaccines and how do we communicate, science with her patients who are, just like you mentioned earlier, these patients are wanting answers. They don't trust the regular quote unquote system. And we have the ability to have relationships with our patients. And so I think that by pushing forward on clarity when it comes to the HSA, when it comes to the bills that we'll be talking about, I think that this is really a moment where physicians are really being empowered rather than just, accepting the contracts and accepting the status quo when they choose DPC over going into a contract with a large system. So let's talk about the bills, because now that we're in a new Congress, we have different numbers for the bills, but the bills are generally, mentioning the same things that we had in September. So can you please tell us about the two bills and what is in each bill?
Yeah, so the two bills that have been reintroduced, and Senator Bill Cassidy, Dr. Cassidy, chairman of the Help Committee, is going to reintroduce the Senate version of HR 1026, the Primary Care Enhancement Act. This would make DPC agreements compatible with HSAs. As I think we're all aware, under current law, if you have an HSA and you have a relationship and a contract, an agreement with a DPC practice, you are currently not allowed to fund that HSA. So, largely you're prohibited from not only from using the HSA to pay the DPC doctor, but in fact, you're even prohibited to fund your HSA if you have an agreement with a DPC practice. So this bill would correct that for low dollar DPC practices that are not concierge practices, but real direct primary care. There would be an exception for those that would allow you to fund your HSA and take the money out of the HSA and spend it on the fees for direct primary care if you are, an HSA holder. Many of these agreements are through employer-based agreements that are tied. HSAs have to be tied to high deductible health plans, and that link is where some of the regulatory problems come in. This bill fixes that, and we're going to talk a little bit more about budget reconciliation and the one big beautiful bill that you're all hearing about on the news. But Republicans on the Ways and Means Committee have proffered that this bill be included as a part of the budget reconciliation process. And we'll get to talk about that more. But what this means is they're taking this bipartisan idea of the Primary Care Enhancement Act, and they're going to put it into a very partisan process. But we've talked to the sponsors of this bill, Dr. Kim Schreier from the state of Washington, who's a pediatrician and one of the leads on the bill, and Brad Schneider, the lead on the bill from Ways and Means, and frankly, they know what's going on here in the budget reconciliation process, and we're working closely with them, and they understand that we're going to do this partisan dance, but we are still urging everybody. Our primary message is for everybody to contact their members of Congress and have them support the Primary Care Enhancement Act, which is HR 1026. It'll be introduced with a new Senate number this coming week. So we'll get back to you with that. And I'll take a breather. We can talk a little bit more about that. But we also have another bill that would treat DPC practices in Medicaid in states that want to engage in that area. But maybe we'll talk a little bit more about the HSA thing now, Maryal, if you have any other questions or places you want to take the conversation.
Yeah, I do think that the HSA is a really hot button topic when it comes to the direct primary care world and ecosystem. When it comes to HSAs, there's lots of chatter about can you or can you not take HSA as payment. And so when it comes to you mentioning that a person cannot technically fund right now their HSA and use those dollars to pay for a DPC. To me, one of the things I want to call out here is that there is still, verbiage in the IRS. It's the last regulatory body that is really looking at DPC like we are insurance. And I'm sorry, I'm not United Healthcare. I'm sorry, I'm not a big Buca plan. I'm an independent doctor up in Northern California. So
I'm not sorry.
Talk to us about this history, because when it comes to, the HSA, there's so many people. You mentioned how employers are also, going into self-funded plans to hire independent DPC doctors to have at the forefront of their care system. So tell us about the HSA and where, it's caused such a ruffle in all of our feathers all of these years.
Yeah. Well, this is language that goes back over 20 years. It has never been amended. It passed as the part of the Medicare Modernization Act of 2003, which brought in the Medicare Part D prescription drug program. And then it was just one of those adjunct pieces of legislation that passed. The rules say that if you have an HSA, it must be paired with a high deductible health plan. The two are linked. So that the way the rules state, black letter law says if you have a health plan or insurance plan that covers things that are not part that are covered within the confines of the high deductible healthcare plan, such as primary care. Now, we know no high deductible health plan covers primary care the way DPC does, but in the eyes of the IRS, that black letter law says, hey, if they offer some primary care in the HDHP, you cannot offer it as a second health plan or another kind of health insurance that would cover things kind of like a Medigap plan that aren't covered in the high deductible health plan. So that's a prohibition that needs to be corrected. In the last Trump administration, they attempted to do this by regulation. The IRS did rule that for the purposes of HSAs, that direct primary care agreements were in fact qualified health plans. That's an interpretation we already understood existed, but they codified that and made that part of IRS regulations. But now it's still problematic because you can't take that. Even though it is a qualified health plan, a qualified health expense under Section 213D of the Internal Revenue Code, funding that still prohibits you from funding your HSA. So these are rules that the bill would fix pretty simply. The new administration may take another stab at a regulatory fix, but we kind of believe it's black letter law, and we need to have Congress change the law to have that fix be permanent.
And then can you tell us more about the verbiage within the bill also when it comes to this $150? Because people are like losing their minds over this $150. And I would love if you can provide some clarity as to what the words actually say and what that would mean for DPC doctors if the bill were to pass.
Well, I hope nobody's losing their mind because, as restrictions go, I will say this was a limitation put in there that candidly we didn't support. But when you look at a bill that's moving through Congress, it has to be scored by two organizations. If it impacts revenue and the Treasury, the bipartisan Joint Committee on Tax, and the bipartisan Congressional Budget Office. Both of those organizations have said, if you put this law into place, people are going to put more dollars into their HSAs. They're going to take dollars that would have gone into tax collection and into the Treasury, and use those pre-tax, triple tax preferred income. In other words, money that goes into the HSA, it isn't taxed as it goes into the HSA. It isn't taxed while it sits in the HSA. And if you take it out and spend it on a qualified health expense like DPC, it isn't taxed then. So we're taking tax preferred dollars to support the idea of primary care. The score on this bill is it would cost new tax revenue to the Treasury to be lost to the tune of about $2 billion over 10 years. And so to keep that number down, even at that $2 billion level, they have said that the exception that allows a DPC practice or a DPC agreement to be compatible with an HSA, that we're only going to let this apply to DPC agreements that are less than $150 PMPM. And I think that fits about 99% of DPC agreements, and that will be moving forward indexed with inflation. So, that'll be $160 the next year and $180 eventually, so it'll be indexed with inflation so that it keeps up with inflation. We thought that was a reasonable price to pay to keep the score down and to keep this in the realm of the possible in terms of getting it done as a legislative item. Strangely enough, that puts us into play in the budget reconciliation process, because to be a part of this budget reconciliation bill, you either have to cost money or save money. We candidly think we do both. We think we will definitely cost the revenue Treasury money that's not going to go into it because people are going to use their HSAs to pay for DPC. But then we also think we'll create some savings in the healthcare system by doing things in primary care that would have otherwise been done in specialty care and hospitalization. And as we've seen, the Milliman study has shown that we can reduce employer expenditures in primary care by as much as 20% by front loading it with DPC and doing more in primary care. So that limitation does not put a cap on what you can charge. It simply says to have this exception in the tax code and to be able to use that HSA with your DPC, it's gonna apply to plans that are below what is well below the national average, which is, I think, something like $72 currently, a DPC plan. It also keeps it out of the realm of the more expensive concierge plans, so we're not giving a tax break to the rich who can afford to pay for concierge medicine. So that's really why these supposed caps are there, and I don't really see them as caps, but limitations on where the exception applies.
And here I would definitely encourage, this is going to be recorded and shared on social media, whatnot, but make sure that you send this to a friend or another DPC doctor. Excuse me, another DPC doctor who hears 150 period and they're not hearing the actual verbiage of the bill, because I do think that is one of the most common questions I get about this HSA bill in particular is, doesn't that mean we can't charge more than $150? And so I think that sharing what Jay just mentioned is really important for those people who wish to understand the details there. Now let's talk about the Medicaid Primary Care Improvement Act, because this is another one where I talk with people and people are not sure, one, where to find it, the verbiage, and it's literally a very short bill, but also what does it say? Because it does not say that this bill equals DPC will be taking insurance.
No, it certainly doesn't, and that's not the intention. HR 1162, the Medicaid Primary Care Improvement Act, again, another bipartisan bill led by Representative Dan Crenshaw from Texas and Dr. Kim Schreier, pediatrician from Seattle, Washington area. And what the bill simply says is that if a state would want to figure out a way in that state's Medicaid program to do direct primary care as a way to administer a primary care benefit as opposed to fee-for-service in the Medicaid program, that state can convene a meeting essentially with the direct primary care doctors in the state Medicaid organization, and CMS, the Medicare agency's Medicaid agency in Washington, to sort of figure out a plan on how to do it. So it really doesn't suggest a pathway forward. Good news, bad news. Good news is that, some states might decide, hey, we want to do DPC and Medicaid, and there would never be a situation where there would be any kind of mandatory assignment. But the way we might want to do it would be that Medicaid would pay the doctor $25 a month and put all kinds of burdensome reporting requirements. Well, that's not going to be an interesting idea for most primary care doctors these days. But what if a state, maybe a red state, would be to proffer an idea that looks a lot like the SNAP program, the food assistance program, which used to be called food stamps, where in that state, money was put into an account, sent to a debit card, to allow you, the Medicaid beneficiary, who has to be eligible for Medicaid under any other way, to pay the doctor a reasonable fee that would be reasonable for a low-income patient to get DPC services into that account. And instead of the 90% of FMAP, the federal matching funds, going into the fee-for-service payment for primary care, what if that went into a payment to the individual that could pay the doctor? So that's an idea we've talked about in states like Kansas and states like Texas that probably wouldn't want to have a draconian Medicaid insurance scheme that is going to do that. And by and large, what the bill does is it sets up a forum led by DPC doctors in the states that's going to allow for a conversation about how this can happen. Technically, there's no rules currently prohibiting a state from doing this in federal law, the way there are some prohibitions. But we've had states like Michigan, for instance, in the past ask to do this, and CMS has not responded favorably. So the legislation would really set up a rubric that would require CMS to come to the table and do this. Now, the good news is we have socialized this with a lot of the new folks that are in the new administration, and they're very keen on this idea. I mean, I think they really want to do this. We may see some regulatory movement towards trying to figure this out without needing the legislation. But, we're about to go down the road of a massive Medicaid reconfiguration in this reconciliation bill. And I think there's a lot of room in the legislative conversation for this bill And again, I think we're going to put up on the screen the links to the bills where you can go and look at the white papers that we've put together for people who come and lobby the Hill with us at the Direct Primary Care Coalition. So we'll show you the actual bill. It's pretty narrow, and I do believe that. It looks like the links are in the comment section. I do believe that what it does is it really sparks a conversation. Now, as we move forward into reconciliation, who knows? We may see further conversation about, what this, Medicaid SNAP-like program might look like, and we're socializing that with a lot of people right now, and members of the DPC Coalition Steering Committee, and we'll have a lot more conversation about that. But there's a lot of good ideas out there. Medicaid is fundamentally a state program, so we want states and the doctors in those states to figure out a way to get the most needy Americans access to a good primary care relationship with a DPC doc. And we think there's a way to do that. And we think there's a way to do that that'll make Medicaid improved and save money.
And this is why, again, I just harp on this so much, that this is where it matters that physicians are sharing their stories. Because if a physician is going into, from residency to, their attending job after their employment through the residency, and then they're getting, pennies on the dollar, and they can't make their own clinic survive to be able to take care of patients, that's something that we've seen with the current healthcare system. We've seen what happens when there's, $700 to $800 per member per month for these Medicaid, Medi-Cal beneficiaries. And where are these people actually accessing healthcare? How good is the quality of the healthcare? This is not, the doctors are not wanting to deliver the healthcare. There's no time. The system is broken.
Yes.
And so when you have the opportunity and the time, because in DPC we have the time to craft our schedules. This is why I love going to be able to share my story in DC along with the other doctors who've joined us in the DPC coalition to say, this is not tenable to have a primary care doctor be forced to see this many people per hour and be able to, get these pennies on the dollar, and it's not sustainable. And so this is where, again, I really appreciate, Jay, you going into the details there, because again, we have the ability to take back our profession as physicians, and we have the ability to take our profession back by sharing our stories and saying, like, this has been tried and this is what cannot happen again. We especially, I love when Dr. Garrison Bliss is in DC with us, because he and Dr. Erica Bliss, experienced the capitated concerns with Q Lions. And so the conversation is definitely continuing. But again, this is where we'll talk about how you can get involved as we wrap up and go to questions. But when it comes to budget reconciliation, Jay, tell us more about that, because this is coming up soon. And so this is really important, especially given that the next DPC coalition meeting is coming up also just in a few days.
Yeah. So May 7th, the day we will be in DC for the Primary Care for America meeting and the DPC Coalition Steering Committee meeting, the Energy and Commerce is set to meet on this task called budget reconciliation. And the primary goal of the budget reconciliation process is going to be to pass this, what they're calling the One Big Beautiful Bill, which will allow, among other things, the Trump era tax cuts from the first Trump administration to be extended to 2034. To do that, they need pay-fors. They need to figure out a way to pay for those tax cuts and to do the other policy things that this administration wants to do, some of which are in healthcare. They have tasked each of the congressional committees with going back and finding savings at their committee. Now, when the Senate passed their version of the reconciliation bill, they said that they passed an amendment that said this cannot involve cuts to Medicare and Medicaid. The Energy and Commerce Committee, on the other hand, 93% of the discretionary spending that they do comes non-Medicare discretionary spending comes from Medicaid. And so it is virtually economically impossible for them to do, something that brings back their target, which is an $880 billion savings over 10 years, without making some changes to the Medicaid program. The changes that have been suggested right now look a lot like this. My understanding is they're looking at taking all of those people in the Medicaid expansion states, in other words, working age, working adults, able-bodied working adults, or those who are able to work, from 100% to 138% of the poverty level, and taking those folks out of Medicaid over a 10-year period, and eventually having them be covered either by employer-based coverage or in the exchanges. The other thing they're looking to do would be to either ban or significantly curtail the ability of states to have provider taxes levied on providers who see Medicaid beneficiaries, and manage care taxes to the MCOs that run the Medicaid programs in those states. Republicans have said that there's a little bit of a shill game going on where those taxes allow the state to raise Medicare rates by charging the taxes, paying the providers more, and then having the federal government at its 90% match pay that. So they're looking at a way to smooth that, reduce the number, the amount that those taxes can be. And by the way, this was a bipartisan proposal to cap provider taxes under the Obama administration as well. So it's not just a Republican proposal. And then to, of course, add work requirements and along with that, provide some state flexibility so that states can do things different in the way they deliver primary care. So rather than framing these things as just cuts that are going to leave people without coverage, could we do direct primary care in Medicaid in the state of California and actually reduce the expenditure in primary care for Medi-Cal, reduce the federal burden of that expenditure? These are the kinds of things that are going to be on the table in this reconciliation package. Now, I think at the end of the day, a lot of these flexibilities will be left up to the states to decide. The more than likely outcome to this will be to have these vast changes to Medicaid happen as a series of reductions in the number of people that are in fact covered, and to move those people into other programs like employer-based coverage or into the exchanges. And there's a lot of, okay, well, how are we going to do that? Provide me with the details. The devil is in the details, and we haven't seen those yet. Energy and Commerce will be marking up that bill on May 7th, which is next week. And so we'll see a little bit more about the direction they're going to go in when we see the language a couple of days before that. But we're working really closely to see things like the Medicaid Primary Care Improvement Act be a part of that conversation in some way, if it can be shown that that can help reduce the expenditures of Medicaid, not just simply cut people and leave them out on the sidewalk without any coverage. I think it's important to talk about, what exactly is this process a little bit. It's very arcane, and essentially, the budget reconciliation is a gimmick that's used to keep things within the confines of a budget conversation. So everything has to be germane to the budget. So anything in that conversation about what's in this legislation is either going to have to spend money, save money, and it's going to have some relationship to the federal budget. So in the case of HSA DPC legislation, it actually spends money. It doesn't really spend money, but it costs the federal government money. It has a budget implication because it's saying, as a policy of the United States government, we want people to withhold money that would otherwise go into their paying their taxes, put it into HSA to save to use on direct primary care. So there's a budgetary impact. So that's an item that could be germane in the conversation about budget reconciliation because it has a budget impact and it has a cost associated with it. The other bill, the Medicaid Primary Care Improvement Act, the problem we have with that is it has a 0 score. It does not impact the federal budget one bit. So it doesn't really have a budgetary impact. So whether or not it will be part of the conversation will be left up to the way the language is drafted about what those cuts look like. Are they state flexibilities for Medicare, Medicaid in California and other states to be able to deliver care in other models? That could provide a window, but the language as drafted isn't likely to be a part of that. This is a process that the Budget Committee and the Speaker of the House has said they want to wrap up by the end of May. I think in politics we have ponies and unicorns. You know, it's possible that for your birthday, you might get a pony. It's not likely, but it's certainly possible. You know, a unicorn is probably off the table. What I think passing the budget reconciliation bill by the end of May is a unicorn. Congress loves a deadline to force events. And I think the deadline that's forcing this event is really, the end of the fiscal year, September 30th. So I think we'll see this process play out. What does this mean for DPC? Stay tuned. Hopefully it'll be a vehicle that we can use that will, in a partisan way, allow us to fix the HSA problem and allow us as a vehicle for that Primary Care Enhancement Act to fix the HSA problem, and will allow us to explore new flexibilities in Medicaid. But, it's a work in progress. And, one of the reasons it's been kind of quiet in the first couple of months is that we've really spent a ton of time with the physician members of Congress and others on Capitol Hill, trying to socialize the idea of how DPC can help in this equation and balance that bipartisanship that we've always had with DPC with our Democratic friends who are none of whom are going to vote for this bill, but some of whom I think are supportive of, hey, if we can get the HSA thing done, let's get it done. If we can, if the making lemonade out of the lemons of fewer dollars going into Medicaid could be, hey, we could move some people into DPC and Medicaid in an appropriate way, let's explore what that looks like. That won't be in budget reconciliation, a bipartisan conversation, but I think it's fair to say it still has some bipartisan support.
So let's talk about how people can get involved. If they're a physician, if they're a supporter of DPC, if they're a patient, how can people get involved in order to share their stories and have their voices heard by the people on Capitol Hill?
Well, the number one thing is we would encourage anybody who's in the DPC movement, whether you're a physician or not, to join the Direct Primary Care Coalition. The website is dpcare.org. And if you go there, one of the things you'll see is we're having our next DPC steering committee meeting and a sort of a truncated, smaller fly-in on May 6th, preceding the Primary Care for America meeting, at which I will be hosting a panel with Dr. Jeff Davenport, who is the president of the DPC Alliance, and Fritz Bush of Milliman, who authored the landmark Milliman DPC study for the Society of Actuaries. So we would encourage people to come to DC next week. Join us at our steering committee meeting, which is at our offices in the Hall of States on Capitol Hill, right across the street from the Capitol. If you can't join us in person, join us virtually. There are links at the dpcare.org Direct Primary Care Coalition website about how you can contact your member of Congress, tell your story about why DPC is important. And our message is very clear right now. It's not complicated. Co-sponsor HR 1026, the Primary Care Enhancement Act, and co-sponsor HR 1162, the Medicaid Primary Care Improvement Act. We want members of Congress to show their support for these bills, whether they go by budget reconciliation or go standalone or any other method, by getting them to co-sponsor the bill, to say they support the bill. The best way to do that is to tell your story about why their constituents are going to have better primary care if you're allowed to deliver that primary care using DPC. And I wouldn't say you do anything else but tell the story about why DPC is, number one, so good for your patients. Always put the patients first. And number two, why it's a better way for you as a well-trained physician to practice at the top scope of your license the way you are trained to do.
Absolutely. I go back to how it is so amazing to stand on Capitol Hill and you think about, I'm in rural Northern California, and to me, I'm like, oh, who's going to listen to me in rural Northern California? But even just between the two times we had fly-ins last year with the DPC Coalition, it was incredible to see staffers of these offices of people who make these decisions, who sit on these committees, say, okay, remind me again what DPC is, to then the next time saying, all right, so that conversation we already had, we've talked to these constituents, and this is amazing. How do we get it into our community? And so I think that's really, really empowering. And yes, there has been a change in administration, but no matter what, healthcare is something that we can improve on as a country. And these are ways that we can approach a better future for everyday Americans without raising taxes, without, allowing the corporations to go crazy, even more so than they have the big buka plans to just keep ballooning. This is a way that we can stand our ground and say, look, as primary care physicians, we can actually do better for our patients and for the budget overall. So it's incredible to talk with you about this, Jay. And I will say, do you have anything else here that you'd like to share with the audience in terms of how we advocate better for primary care?
Look, I mean, I think you just very eloquently put put the nail into the coffin here. You got to get involved. This isn't hard. This is like you would talk to any other patient or any employer or anyone else in America about why you love doing DPC and how great it is for your patients. Come to Washington and do that. It isn't that hard. If you don't want to come with all the rest of the doctors in the in the fly-in, and you just want to do it individually and come and tour the Capitol, reach out to us. We'll help you do that. We can help you with the messaging points. I think you've got the links to the talking points and the one-pagers that we hand out. They're very simple. I will say kudos to Maryal because she helped us redesign these sort of very wordy fact sheets into really nice infographics that tell the story. And it really is so appropriate that your podcast, My DPC Story, has teed this up so nicely, because all it is about telling your story and sharing the good news about really what we're doing in direct primary care to give better primary care to sort of all Americans of all income. We want to do this in Medicaid. We want to do this in Medicare. We want to do this for the youngest and the oldest, cradle to grave. We want to do this for the military health system, for the VA, for every, regardless of the payer. This is the point. We want DPC to be outside of fee-for-service payments. Over here, we still want you to have insurance. And if the VA is giving you that, or Medicaid is giving you that, or Medicare is giving you that, or you're sort of self-insuring, as a lot of people are doing who are falling through the cracks, particularly in some of these red states that don't accept Medicaid expansion for the lower income people. I think it's really critical that everybody have the opportunity to have this. It's affordable. In some states, Medicaid pays for a cell phone for people so they can talk to their doctors. For the price of that cell phone bill, you can have a personal relationship with a primary care doctor. Why wouldn't we be doing that? And candidly, the biggest question we now get when we go to these offices is just what you said. How do we get this from the constituents in my state? It isn't like, how does it work, or pushing back because, it's not real insurance, or, any of this stuff. I mean, it's the debate has evolved because so many physicians have spent their time and left their shoe leather on Capitol Hill telling this story.
Yeah.
I think that's really it. I would be more than happy. I do think we have some time left. Am I right about that?
Yeah. Let's open it up for questions.
Yeah, I'd be more than happy to answer any other questions. That's where I was going to go, and talk about some of the other things that are happening in DC. Whatever's on your mind, we're covering not just DPC, but really all the gamut of all the issues that are impacting healthcare today that are ultimately going to impact your patients.
So let's see. I'm trying to see the question. Here we go. In the past, here's a question. Thank you, David. In the past, policymakers at state and federal. Oh, here we go. There's our question. So I'll just read it for those of you who are maybe listening and not watching. In the past, policymakers at state and federal level would equate health insurance with health care. Oh, I love this. Are you seeing any progress on this front? Can this help drive more innovation and improvement in U.S. healthcare? I'm going to let you go because I'm going to blow up the microphone with my answer of hell yes. Excuse me.
That's appropriate because this isn't just a legislative question. And you're absolutely right, David, that let's talk about the bargain equation for the Affordable Care Act, right? The bargain equation for the Affordable Care Act wasn't, in fact, that every man, woman, and child in America was going to get health care. It was that they were going to get health insurance. So what we have been doing since the passage of that, and the seeds were planted in Section 1301A3 of the Affordable Care Act, to actually provide a new pathway for individuals to get true health care provided by their physician in addition to health insurance. I actually believe you need both. And for bus accidents and cancer and fires and trauma, you definitely need health insurance, but the reality is 96% of the healthcare, and this isn't a fact that I pulled out of anything but my head, but most of the healthcare you're ever going to need in your life is going to be delivered by a primary care doctor. And that primary care doctor ought to be somebody that you have a relationship with. And DPC provides a pathway for that. I would also say on the legislative front, I do believe we're going to have that consideration talked about a lot more by the physicians that are in this administration and in Congress. And states are looking very, very closely at new rules around corporate practice of medicine, around limitations. Arkansas just passed a law basically that says a PBM can't own a pharmacy and can't do a prescription program. I think the tragic shooting of the CEO of United Healthcare showed how frustrated the American public is with the gamesmanship that insurance puts on the delivery of benefits, even in primary care. And I think legislators, policymakers are responding, and we are at a tipping point. And I think coming to Washington next week or over the course of the next few months to express a pathway through DPC of how we can get to actual health care rather than just health insurance, and how the two together work efficiently, as we pointed out, and as we proffered in that seed language that was put in the Affordable Care Act, that allows DPC to provide a part of the essential health benefit alongside of a qualified health plan. We have a lot of thoughts and ideas about how that could work. We have great ideas about how it could work in Medicaid too, which we've talked a little bit about today, that I think are going to be really impactful in the conversation that's going to unfold about the changes to Medicaid in the coming weeks.
And I do think here, one strategy that I love is just collecting these examples of how health insurance is not healthcare. Specifically, there was a conglomerate who bought out a hospital organization. And in this one county in Northern California, 60% of the Medi-Cal beneficiaries lost overnight their access to healthcare because they did not, this company no longer took their insurance. And so I think that by having these examples ready from all over your state, from the nation, these are the things that you can be prepared with in your tool belt when you talk to somebody, whether it be through the DPC Coalition meetings on Capitol Hill or with your own community. So we'll go to the next question. Mehul Agarwal is asking, how can policymakers leverage outcomes and cost data from direct primary care models to shape legislation that promotes value-based care while differentiating DPC from traditional insurance under federal and state law?
So at the end of the day, Mehul, I would say this. The American Academy of Family Physicians has long said that particularly for the small solo or small practice family physician, internal medicine doctor, primary care doctor, that of all the value-based care models, direct primary care is the model that provides the most value. Value-based care has turned into, I think, kind of a metaphor for the ACO. So it's come in to mean, value-based care arrangement means where you're going to get paid a PMPM in addition to fee-for-service payments and a bonus payment in a very complicated structure that's going to require a lot of measuring and reporting for you to get less money. So what if a value-based care arrangement in CMS looked like this? Doctor is paid a flat PMPM payment of $120 to take care of a Medicare beneficiary. He can no longer bill in the Medicare physician fee schedule fee for service, but if he's opted out of Medicare, he can provide that care to a Medicare beneficiary for $120. And there would be encounters measures about how many times you've talked to the patient, filed twice a year, and a report on all of the referrals that were done once a year, and otherwise, anything you do for a Medicare patient for $125 a month or $120 a month or whatever the number is, will be covered by this $120 fee. So that would be, I would say, a value-based care proposal on steroids. And how do you measure it? Well, if you do it for 3 or 4 years and you're not saving money and your patient population isn't improving, we won't do it anymore. So this is an idea we've proffered to CMS. In addition to the idea, you probably can't do the EBT program in Medicare or the value-based program in Medicare, but in Medicaid, again, what if we put it into a Medicaid primary care assistance program that looked like SNAP, and you allowed the Medicaid beneficiary, to contract directly with a doctor as a part of the Medicaid beneficiary. This is something Seema Verma in the first Trump administration talked about when she first got to DC, and it was an idea that probably wasn't ready for prime time. Is it ready now? It might be. So I would say look more broadly as to what value-based care can be. Don't define it as the ACO that we know it's kind of come to be, and allow us to work with policymakers to make those arrangements look better and look more like DPC. That would be my answer.
And one question coming from backstage is regarding where DPC is in the states, because this is something where DPC is not necessarily protected by law in all 50 states. 34 is the latest as of last August. And I'm in a state where we do not have DPC law. And so, Jay, I would love for you to talk to us about where DPC is in relation to these states that don't have DPC laws that protect them, especially given that, there's so much on the table right now where, again, if we use our voices to speak up for what we're doing and share what we're doing with everybody, patients, policymakers, et cetera, that, this could potentially make an impact on protecting DPC in the states that do not have the protection currently.
Well, I think there's going to be a flurry of new activity in the states based on what's likely to happen here in Medicaid coming in the coming sessions. But as you're probably all aware, we've been in 34 now states passing legislation that defines DPC as a primary care medical service that's regulated by the state medical board, not by the state insurance commissioner. The second, I think, where we spent the most energy has been in trying to help in some states like Texas and Massachusetts that absolutely prohibit physician dispensing of medications. We've been trying to change that. Now we're running up to the end of the Texas session. There was just a hearing Monday in Texas where an idea was proffered that in exchange for the idea that a pharmacy or a minute clinic might be able to test and treat strep, COVID, and flu in that environment, that physicians would be able to dispense a range of medications, probably not controlled substances, but a range of medications in their offices. So we're looking at a number of states that are looking to change that. Texas is one of them. I'm not sure where that legislation is going, but we support that concept. The bill that was put forth didn't wind up to kind of look like that. So we're not quite there yet, but we're working really hard in Texas to try to change that. And then in a couple of other states, Massachusetts, Maine, Texas, and others, we're seeing a flurry of legislation that is responsive to insurers trying to clamp down on the ability of DPC docs and other docs that are just plain out of network, being able to refer to specialty care and other services from outside of the network into these narrow networks. So we're going to really focus on this in the coming year, work closely with states on some model legislation that would basically say, hey, if you're a licensed practitioner in your state, you should be able to refer for specialty care into anybody's network. That denying care based on what network you're in, particularly for a patient that has paid out of his or her pocket to get a DPC arrangement that is outside of the narrow definition of what primary care is provided for within this HMO, that you ought to be able to refer into anybody's network. Representative Thomas Walsh from Massachusetts has introduced a bill in the Massachusetts state legislature. Jeff Gold from Marblehead and I have worked really closely on this concept. We're going to talk a lot about it in our meeting that's upcoming and really make this a push, because I've seen a lot of complaints from the members of the Direct Primary Care Coalition that this is an issue that is more and more pressing in the states, and it's something we're going to focus on quite a bit. And Maryal, I'm excited that the Direct Primary Care Coalition has a new affiliate in California, the Cali DPC Coalition, and you're going to be hosting your own meeting in addition to the meeting we're hosting May 7th, and we hope you all attend at dpcare.org. So really excited to maybe, I think in California, the issue isn't so much that you can't do DPC, is that the regulations are confusing, and we want to begin to try to fix some of those.
Yes. And if you're listening in a state like California, you have the opportunity and you have this amazing, time in history where your voice can make a difference for the future of America's healthcare. So thank you so much, everybody, for joining us today. We look forward to seeing you in person, and send us questions. Thank you.
Take care, everybody. Great talking today.